Hi, my name is Dr. Raja Adnan Ahmed, and I'm a consultant psychiatrist working in UK. And with me today is Dr. Motiani. And this is part of our interview series when I'm inviting some successful IMGs to talk about their specialties. Dr. Motiani has secured his training in Ops and Gynae. He'll be starting from August 2020. He has a very good story to share around how he secured that position and advice for the IMGs looking at the same sort of area. Other thing with Dr. Motiani, he mentioned to me was that he also had a clinical gap for more than 12 years. And a lot of IMGs worry that if they haven't worked clinically, would they be actually able to accommodate in NHS? A lot of people say that, is there a place for them in NHS? So he's a very good example of somebody who made his place in NHS, and not only his place in NHS, but done his foundation training here and also now moving on to a training post. And I'm sure he will be a very successful doctor in that sense. Uh, Thank you very much, Dr. Motiani, for joining me.
Not at all. I'm glad I'm able to help the new generation coming through, because obviously they need a lot of help and guidance available out there.
So would you like to share your journey so far, some summary of your journey of how you came to apply for Obs and Gynae and, this part of the world?
Sure. Well, so obviously I've done my training, I've done my MBBS from Dow Medical College in Karachi, Pakistan. I graduated in 2005. So by the end of my final year, I knew I wanted to pursue a career in obstetrics and gynecology, because I honestly didn't see a fit anywhere else. And it's rather unusual because the way things are in Pakistan and the way society is out there, it's very, very uncommon for a male physician to go into obstetrics and gynecology, because every time I'd mention that, everyone just would be like, why? I mean, that was the big question. But as I said, I didn't see a fit for myself in any other specialty other than in obstetrics and gynecology. So I knew this was the path I wanted to pursue. So when I graduated in 2005, I immediately went in to prepare for my steps, because the plan was to apply for training in a residency in the US. And I knew it was going to be very competitive. And so I sat the steps. Unfortunately, I didn't score too well on step 2. And that was probably one of the biggest hurdles for me when it came to securing a job in obstetrics and gynecology. I went through 2 matches without, I got some interviews, but I went without a placement. So as a compromise, I was willing to give family practice a go. In America, if you're in the rural side, family practitioners are the ones who step in the role of an obstetrician, and once obviously they've gotten a further fellowship in obstetric training. So I was like, fine, as a compromise, I can go down that route, become a family physician, then go into a fellowship, and then maybe practice in an semi-urban or in a rural setting where there are no obstetric services. But as I said, while I was making that plan, another hiccup that I basically got into was the fact that I ran some immigration issues, which just meant that I didn't have the visa to appear in person. And if you don't have that visa to sit in for interviews, you basically can't compete in the match. So the other option was then to consider and see what else I could do. One thing I was clear was that I was not going to pursue further training in Pakistan at all. There were some personal reasons for this, which I'm not going to talk about. But the other main reason was the fact that as I said, it's unheard of. I mean, obviously there are some people who are practicing in the area, but it's unheard of. And so what I did was that I went into a honorary house job at Civil Hospital in Karachi. And that's where I'd done my medical training as well. It was the hospital attached to Dow Medical College. And when I was there during my 4 months, I had a great time over there. Obviously, I was the only male physician in the department, in all 5 units, in fact. 4 units at that time, 3 at Civil Hospital, 1 at Liari General Hospital. So amongst the 4 units, I was the only male physician there. In fact, I was told that there's no toilet available to me on that floor. So I'll have to go up to urology. So I had to always run up on floor up. So that's just saying that there were no provisions for men on the floor. But I was given a lot of exposure, and everyone just took me under their wing and helped guide me. And as part of that guidance, all the postgraduates I came across, they told me basically, if you want good training, especially being a male, you should go abroad. Because a lot of things that we do in practice are just not practical in Pakistan. And things like giving patients privacy at such an important time in their life and especially in a public hospital, the largest public hospital of Pakistan, is just not feasible. The lack of resources. I remember for CTGs, we could only do 3 CTGs only throughout the day. So you can imagine out here, any woman who's in high risk, which most of them are, and if they're especially in a consultant-led unit, they all get not only 1 CTG, they get continuous CTG monitoring, and a lot of interventions, especially if you want to call a category 1 C-section, are based on findings in the CTG. So you can just imagine there's a lot of pathology. Unfortunately, there were a lot of deaths, in utero deaths. There was a lot of pathology. So it was an amazing experience. But at the same time, I knew the limitations, and everyone basically said, if you want to be trained as a proper physician, just go abroad and pick up good habits. So that's when I made the decision, I'm not going to pursue any training in Pakistan. And as I said, there were also personal reasons because of which I'm unlikely to return to Pakistan to further my career, even once I have trained. So at that time, the only option with America, me running into immigration issues, and then Pakistan being a no-go for myself, UK was the only other option. And at that time, this was around 2008, recruitment into the UK was very restricted because of immigration. Because I had not done my house job, obviously I was aiming to start at the foundation program level. So another thing that I was doing by the side was the fact that I'd already, so to say, lost 2 to 3 years since graduation. And on paper, that didn't count for much because not only did I not complete my house job, obviously the MLEs really don't, if you're not in America, the MLEs don't count for anything. So on paper, practically, I hadn't done anything for the last 3 years. I was doing some research in the lab, but, as I said, concrete stuff, there was nothing going on. So I decided that enough was enough. I need to do something to enhance my portfolio. So at that time, I planned on investing in a master's program, and I was considering a master's in embryology offered by Northwestern University in Chicago. Unfortunately, that program fell through after the first year. There was a pause in recruitment. This is when I wanted to apply. So unfortunately, I couldn't progress on that. Another option was to pursue an MSc in clinical embryology in Oxford. Fortunately, my brother was settled here. He'd come in for his undergrad, non-medical, and also he continued on to his master's. He was already living here. So I was like, okay, fine, I have a house to live in, and Oxford is well known. Let me pursue my MSc over there. So I applied for my MSc over there. I got in great experience. It obviously gets you points as far as showing dedication to the field, as well as giving you points for a higher degree. But obviously it's costly. So I wouldn't think that it would be in the reach of everyone out there. But if you can, and if you gives you opportunity, definitely take that on board. It was a one-of-a-kind program. And if you want more details, you can always contact me. So I did the MSc for 1 year. And the plan was to sit my PLAB and then compete for the foundation program. At that time, because of immigration restrictions, like the old round 1 and round 2, they would only offer any remaining seats on the foundation program which hadn't been filled to people who didn't have UK citizenship or EEA citizenship, or were not married to a spouse of that nationality. So basically, if you needed a visa, they were willing to consider you on the few remaining seats. And usually they would end up going to Pakistani candidates because in Pakistan, the house job or internship is not part of the medical degree. So you do graduate without having done that. And not many countries do that. So in other words, like say, for example, in India, the internship is part of your MBBS degree. So no Indian graduate can actually apply for F1 training positions because by default, they have done their internship. Obviously, that doesn't happen in Pakistan. So I was actually lucky in the sense that I could compete for those places. So I registered for my PLAB 1. Even before I sat my PLAB 1 in 2011, the recruitment for that year for 2011 entry was going on. And this was the summer. And people who had already been issued and given contracts, and people, in fact, had gotten into signing leases because this is the summer. August is when the foundation program starts. So there were a number of Pakistani graduates, about 15, I would think, who basically were on the road to starting their first job. And that's when the Home Office basically threw a bomb on them, saying that you don't meet the labor market test, and that's the reason why you can't be eligible for this job. So it was really unfortunate. These people had spent all their money and resources, sat PLAB 1, PLAB 2 in the hope of getting this position, got the position, had been looking forward to starting a life, and everything was cut short. I was lucky in the sense that I had only registered for PLAB 1 at this point, and I hadn't made much of an investment. But it was also a very dark period in my life because there was nothing that I could look forward to. So anyway, I sat my PLAB 1, cleared it. I didn't go on to PLAB 2 because once you go on to PLAB 1, then you go on to PLAB 2, and then you have to be GMC registered within a certain time. And given that I wasn't going to be eligible for foundation program and I wasn't eligible for any other position, I wouldn't be able to make progress. Now, a lot of people could still say that, you know, with everything going haywire, you could reconsider your position, go back to Pakistan, do your house job, then come in a non-training position, then be eligible for round 1 on the basis that you're already having a non-training position. But again, personal choice, I chose not to do it. I had once made, I'm very stubborn. I'm a Taurian. I'm a very stubborn person. I had made up a decision that I am only going to start from the bottom up. I am going to go into F1 and all my training, I'm going to do it the proper way. So that was the reason why I didn't choose to go ahead with that route. I knew it will be, it'll take a lot of time. Anyone I told them about my plan that, you know, I'll consider a foundation program after securing a job that will give me a visa and eventually a settled status, which would be at least another 5 years. Everyone just said that you're committing professional suicide. No one goes back to medicine after so many years. So this is a call out to all those people. A lot of women who become housewives and then they bring up children and they think obviously priorities with that. And by the time years have gone by and then they think, oh, it's been already 7 years, 8 years, 10 years since medical. I can't go back. No, you can. I am a living proof of that. I had made up my mind that no, I'm going to go into foundation program and nothing else, and I'll wait it out. And that's exactly what I did. I was lucky enough that after my graduation, I was on a student visa. I went on to the PSW visa, which has been scrapped. And that PSW visa allowed you to take up any job. It didn't have to be one that would eventually give you immigration sponsorship, any job in the next 2 years. So in a way, that was a good visa. I applied for that so I could stay in the UK for 2 years. And during that time, I was looking for a position, another dark period in my life. Every position I was applying to, and obviously I was applying for non-clinical job. But obviously, I wanted to keep it relevant to medicine. I'd done some lab positions in the run-up to my graduation. And then obviously the MSc in Oxford was heavily lab-based. So I was looking for a lot of lab positions, but everywhere I went to, immediately it was just like, why would a doctor want to do this job? And why would an Oxford graduate want to do this job? So everyone was very skeptical about wanting to offer me a job position. And it was very unfortunate. And that's when I learned the word overqualified, because in Pakistan, no one's overqualified. Over here, all of a sudden, I was overqualified for all of these jobs. So again, it was a bit of a struggle, but I got really lucky and I got a job, a non-clinical job as a tissue coordinator with the University of Oxford Brain Bank and Oxford University Hospitals, NHS Trust, Oxford Heart Valve Bank. Very unique projects out here. So basically my job as a tissue coordinator, I was a grade 6. It was good pay. And I was sponsored eventually. So I was on the PSW visa. Once I got the job, eventually within the next 1 year, they sponsored me for the tier 2 general visa. And that's when my immigration clock started. I swapped over onto that visa. I stood on the job for 6.5 years. Although it was a non-clinical job, some of the good things I liked about the job, and again, this is something that people who want to think of non-clinical filler jobs until circumstances allow them to go to a clinical job, maybe they can't do nights, and they want a strictly 9-to-5 job. Although there was some flexibility that you needed to show, but it was technically a 9-to-5 job. As a tissue coordinator, what I would do is I would screen through all the deaths within the area, in the hospital, and even outside, and looking for the possibility of tissue donation for transplant and for research. If people met the criteria, I would go through the medical notes. So I was making use of a lot of my medical knowledge, but it was a non-clinical job. So I would screen through notes, look at the criteria. If someone was eligible for tissue donation, I'd look them up on the organ donor register, and then I would contact the clinicians looking after them and the nursing staff, check with them with regards to IV infusions, because you need to get a suitable blood sample for testing if they are going to donate tissue for transplant. So there was a lot of clinical knowledge that I put to use. And the other thing I liked about it was, as opposed to a lab job where you don't use your communication skills as much, this heavily relied on communication, because you were talking to clinicians, you were talking to nursing staff, you were talking to lab technicians over the phone. A lot of it was not face-to-face conversation. So you have to rely a lot on your communication skills. And then obviously you would approach the families as well. And it was a very special time in their life. They just experienced a bereavement. These are very long conversations. If someone donated tissue for transplant, it could be up to, the calls could total up to an hour and a half. So obviously my communication skills developed. I did a lot of training with bereaved families, including Child Bereavement UK, SAGE and Time. There were lots of, obviously I had to brush up on my knowledge about the Human Tissue Act. All of these things I think helped me in my career for obstetrics and gynecology, because unfortunately there are times where families face bereavement and doctors usually aren't skilled to deal with it. The minute they hear about a death, it's like, oh my God, I can't deal with this, because obviously I'm used to dealing with the living people and I don't deal with dead people. So I think that was a very good thing for me, because it prepared me for a future in obstetrics and gynecology, because I could use a lot of my skills, especially with regards to communication, which I could transfer over. And as I said, I've done a lot of training with Child Bereavement UK about neonatal loss or pediatric postmortems, because obviously you need to explain that to the family if there's been a stillbirth, when it comes to filling forms, telling them about the Human Tissue Act and what's going to happen to the tissue, about research. So all of these are skills. That's what I'm saying. Any job you do, you can, although I mean, tissue donation is remotely not connected to obstetrics and gynecology. But I use that opportunity to always keep obstetrics and gynecology at the back of my mind, and then to do things which would obviously help me in the job. But again, things that I could then carry on to obstetrics and gynecology or to a clinical career in the future. As part of this, I've done some presentations, a lot of teaching in the area with police officials, with coroners. I used to deal with the coroner's office on a daily basis. So I would sit in on conversations where clinicians were talking to coroners, officials, and their officers when it comes to discussing a death. So all of these things prepared me for a future in medicine, basically, and not just in obstetrics, because as a junior doctor, you will be having those conversations with the coroner's officer. So as I said, even though I was not doing a clinical job, it was very relevant. It prepared me for a future in obstetrics and gynecology. So anyway, I did that job for 5 years. I also got a national award on one of my presentations over there. And then after 6.5 years on the job, I qualified for the immigration, for my ILR. Indefinite leave to remain. So I became a permanent resident. And that's when I became eligible for the foundation program, because the foundation program till last year was only open, or at least, so last year, things have changed. Last year, all immigration restrictions were dropped. So technically speaking, if I'd waited for another 2 years, even with my Pakistani nationality and not with an ILR or a UK nationality, I could have still joined on the foundation program. But anyway, 2 years back, it was still open to foreigners. So no, in fact, 2018, the year I applied, 2017, I applied for 2018 intake. That was the first year after 2011 where they were willing to entertain foreigners, but again, on a secondary basis. So they would accommodate every British national and EEA national. And thereafter, again, same situation as before, if there were any placements, they would be willing to consider non-EEA, non-UK nationals for the foundation program. That continued for 2 years. So for the cycle 2018, 2019, and then 2020 is the first year where international, anyone who doesn't have a visa or will eventually need a visa to work in the UK, they can compete on an equal footing with British nationals. Now, how that's going to affect the cycle is still underway with the start date of August 5th. I'm sure the UK Foundation Program Office will publish a report saying how they dealt with the cases. But what they did last year was, after round one, they accommodated everyone who had the rights to work. And then in round two, there were still some British nationals and EE nationals who couldn't be accommodated. But then at the same time, there are a lot of people who got the positions, who dropped out. They wanted to join, they wanted to do a gap year, wanted to go to Australia or whatever. Some who unfortunately didn't clear their final year exams, or some who just wanted to quit medicine. So anyway, there were vacancies. So again, they accommodated, and there were different rounds. I think there were up to 5 rounds. And initially, in the first 2 or so rounds, they only invited people who had the immigration rights to come forward. And eventually, they invited others. But unfortunately, last year was one of the first years where, after 2018, obviously there's not been many years, but last year there were 35 candidates who were not nationals who did not get a training position. The large majority did get a position. So it's not a guarantee that you will get the position, but it's certainly worth trying for, right? And then again, that was last year. This year, everyone has an equal right to training. So I don't know how things have worked out. I'm not part of the cycle this year, and obviously the report hasn't come out. I don't know how they were going to treat people and whether there were going to be allowances made for British nationals who end up without a place, because foreigners have been accommodated. But we'll see. But I would definitely recommend joining in at the bottom end and starting your training there, because a lot of IMGs worry about getting their relevant forms, competencies signed up. I didn't have any of those worries, because I mean, the other good thing is that I think it's more difficult. It's difficult stopping your training and then having a gap and then coming to the UK, because then you're answerable for that time that's gone by. If you've done no clinical work like me, like basically on paper, graduated, the house job for 4 months didn't count for anything because I didn't get it paperwork signed up for it. So there was a gap. So the UK is okay about any gap in between medical school and clinical training. Where the questions are raised is when you started your training and then you stopped it and then you want to restart it. That's when they go like, because the expectation level is very high. They expect you to be ALS trained if you are going to ST3, and they want a recent, certification. They want all of those competencies signed off. They think that you're rusted. But surprisingly, if you come out of medical school and not done anything, when I joined in, no one asked me even once what you were doing for the last 12 and a half years, or that you need recertification, or you need to demonstrate your competencies. It was straightforward. PLAB 1, PLAB 2, sit the SJT. This is all part of the foundation program. Do the clinical assessment, because it had been more than 2 years since graduation. I got offered a training position because I had my ILR round 1. I met everything. I got it in Oxford and, well, the Thames Valley region. I got my position at Bucks in High Wycombe and in Stoke Mandeville, because I was, again, chasing a position in obstetrics and gynecology. And so I got my 7th choice, which meant that I spent both years in the same trust. And so it wasn't a difficult process, because this whole idea of getting competencies signed off, it's part of your natural cycle. While you're being trained, you have to do the set procedures, you have to do CPDs, and you need to do reflections, you need to clock in teaching hours, CPD points. Everything is very natural. So that's the one good thing about starting off in a training position, that you don't have to do much. As in, you do, but you don't have to do anything on your own accord. The whole process is set up so that it can facilitate you to eventually lead off to that position. So yeah, Raja, that's me in a nutshell with regards to getting into the foundation program. Is there anything you want to ask me? Yeah, if you think there's anything that I could add on to be helpful to others out there.
Thank you for giving us account of how you got your foundation training. What about if somebody is working in UK right now and they're thinking about obs and gynae training? What would you recommend for them? How should they go about it? They may be working in a medical job, or they might not be. They might not have an obs and gynae rotation as such. In their foundation program. How do you think they should proceed, and what is the procedure of that?
So basically, I'll just talk to you a little bit about the obstetrics and gynecology training. The good thing about the training is that it's 7 years run through. So once you get in, you've gotten a position, you don't need to reapply, or certainly don't need to change regions. Or so when it comes to planning your life, it's more conducive because there's no reapplication involved and you don't need to change positions. So it's much smoother run. So now that I know I'm going to be staying in the Thames Valley region, and since I already have a house in Oxford, I know I can continue living on. But even if I was flexible enough, which I was, and if I had to move away, I know that 7 years I'll be spending in the region. So you can plan things accordingly. So obstetrics and gynecology is open at ST1 level and at ST3 level. It's a national recruitment, like with other specialties. The advertisement is put out in October. You start applications in November. You need 3 referees. You need the CREST form, and then basically some other paperwork that you just need to fill in and send across. There's no more need for proving immigration, so you don't need to provide anything at that point. And then basically you go on to filling out your application, you apply, and then you basically have to appear in for an interview. So this was up till this year. Obviously, COVID has changed things, so we don't know how things will be in the future. But you will be, I forgot, you have to sit the MSRA exam. I'm sure people who are looking at other specialties know about the MSR exam. I'm not going to go into it, but it's the same exam you sit for obstetrics and gynecology. And in obstetrics and gynecology, the MSR accounts for 25% of your final listing for ST1. The other 75 come from your interview. The interview is basically 3 stations, and you in one station is all 3 stations have 2 consultants sitting on them, and they score you. The first station, or at least one of the 3 stations, is about your portfolio. Now, unlike other specialties in obstetrics and gynecology, in the recruitment, you don't need a paper portfolio. You literally go empty-handed. Everything is based on good faith that whatever you say is what you've accomplished. So they'll ask you about your career to date. And one of the questions is why obstetrics and gynecology, and show your commitment to the specialty. So now is the part I'll talk about the question that you raised about showing your commitment to the specialty. Getting a job in obstetrics and gynecology, doing a foundation program is obviously part of it. But if you don't have it, don't feel disheartened, because you can do a lot of other things that can show your commitment to specialty. As I mentioned during my non-clinical job, how I did all of those things. So I presented that, saying that I've had a 12.5-year gap, but during that time, I've always thought of obstetrics and gynecology. I've done my MSc in Oxford. They asked me about research, and I said, yes, I have done a lab project, and I did a dissertation on it. They ask you if you think research is important. If you've not done any research, be upfront about it, that you've not had opportunities. Maybe you came from a country where people didn't engage in lab sciences, or you didn't have clinical research study that you participate, but that you're willing to do it. So they won't really count it against you. Obviously, it's a good thing that if you've done it. So yeah, you could do research in other areas. It doesn't have to be in obstetrics and gynecology. My research during my MSc was on mitochondrial DNA and pre-implantation. So yes, it was related to obstetrics and gynecology, but equally speaking, it was about genetics mainly. So you can always play things around and say that although I've not had an opportunity to do obstetrics and gynecology research, this is the other research I've participated in. I had done research on lab-based research in London School of Hygiene and Tropical Medicine on malaria immunology, as well as gene therapy at Imperial College earlier on. So I could have evidenced those if I didn't have a relevant research in obstetrics and gynecology. So with regards to career in obstetrics, there are lots of different ways you can exhibit an interest. Doing an audit, again, it doesn't have to be one in obstetrics and gynecology. You could say that you participated in that. Again, there will be a question on audits again during the interview itself. Communication skills, it doesn't have to be related to obstetrics and gynecology. As I said, a lot of my communication skills were around bereavement and loss, and I changed it around to say that this will be helpful for me in obstetrics and gynecology. Equally, you could have had a rotation in pediatrics, and you maybe dealt with some neonatal cases where you had to communicate with families and the outcome was poor or it was a positive outcome. You could evidence that, showing your commitment to the specialty. Teaching is another thing you can do on the wards. It doesn't have to be, again, related to obstetrics. So there are a lot of transferable skills that they are looking for. They don't want someone who knows how to do a C-section or who's done so many vaginal deliveries. They literally want someone who can bring over skills that they've demonstrated in other areas for obstetrics and gynecology. So I think that goes for any specialty. I mean, if you want to become a cardiothoracic surgeon, although you'd need to train in general surgery first, and obviously they don't expect you to do heart transplants, but so any little thing that you've done in general surgery or in radiology or in pathology, you can evidence that to show an interest in cardiothoracic surgery eventually. So that goes beyond for any other specialty. That don't be disheartened that you don't have the relevant experience. In fact, like with all surgical specialties, if you've done more than 24 months in obstetrics and gynecology, they actually hold it against you and you're not even eligible to apply for ST1 position. So you are, again, overqualified for it. So definitely don't be disheartened. There are a lot of things you can evidence and basically increase your scoring for the listing. So in the first interview section is basically about your portfolio minus the actual portfolio in hand. So they'll ask you about all of those things on the personal specification and they'll score you accordingly. One thing I was quite hesitant for whether they'll treat you fairly or not. They actually give you a feedback after the interview, and you can see how well you scored with a lot of verbal descriptors about where you did well and where you didn't do well. And I have to say they were very accurate. So I would say I have confidence in the system, knowing that they score you well and you are treated fairly, even if you are an immigrant or an IMG or wherever you graduated from. The second station is always a clinical scenario. There'll be an actor there, two consultants again who'll be scoring you. You don't speak to consultants at all. You are given a vignette that you read outside the door. You know what to expect. You go in, and it's all about communication. It's all about showing your empathy, your concern for the patient. And again, it doesn't have to be a gynecology case. As part of this, in the end, after 10 minutes are over or so, they will stop you. The consultants will then step in and they'll ask you for the differential diagnosis. They might ask you how you'll manage the case, etc., etc. And in the closing one, they'll go visit the scenario again, and it'll be the same patient visiting your clinic with a complaint, and it's all about how you deal with that. So here again, you need to know about the British system, how you escalate things, how you investigate things, how you report things, and what are the patient's rights, and how you guide them to go about filing a complaint, and what you are going to do and how you handle the situation. So obviously you need to brush up on things. If you are part of the UK system, it really helps. I really think immigrants who apply from abroad with no UK experience will be at a big loss, simply because you're not aware of the system. So I remember there's one question which at that time I thought it was a ridiculous question to be asked. I was asked during my first question. It was one of the consultants asked me, if you are the SHO on call in obstetrics and gynecology overnight, who is the team that who constitutes the team you will work with? And I remember coming out of the interview and the next day going up. I was in my O&G rotation at that time, so I went up to my registrar the next day, and I was like, that was a ridiculous question because that didn't make sense. They're like, no, they want to know whether you were aware of the MDT system out here, and you knew who all you'd be able to access. And he said that obviously it was very natural for you because you are currently in an O&G job, so you knew how to answer it. But a lot of immigrants might or people who are out of the NHS might struggle on it, because unlike abroad, how things out here, obviously you have your seniors. Usually you have an obstetrics registrar as well as a gynecology registrar on call, unique specialty with two registrars on call overnight. You have the consultant on call, and it has to be a resident consultant. Again, very different from other specialties. You also have the midwife coordinator. You have the midwives who are assessing and dealing with each of the patients. You have HCAs, you've got porters, you've got the lab available to you, you've got the emergency department available, you've got the blood bank available to you, you've got your OT technicians available to you. You also have pediatrics on call. You also have a resident anesthetist or a trainee who can help with anesthesia for labor. So if you aren't in that environment, you won't know that you will have a HCA available over there. So it seemed like ridiculous questions to me, but honestly, that demonstrated that you know about the NHS and you know about the system out here. So, so I think, yeah, people who come from abroad, if they've not worked in the UK, not specifically in obstetrics, in any specialty, I think they'll be at a loss. Not to say it's impossible, but you will be at a loss. So I would definitely advise getting some exposure and working in, even if it's in a non-training position, because there's a lot of learning to be done. Because things like consent and things, they go across the board. It's not just related to obstetrics and gynecology. You will be faced with that in a in a surgical job, in a non-surgical job, in radiology. Even consent is important. So there are a lot of things that you can pick up from those jobs over there.
So I think you were, I think, meant to say maybe that if you are not working in obs and gynae, it's better to sort of go and ask for some experience in your local department, maybe a week of experience, or you can spend half a day, a week, or something like that attending the MDT or sort of understanding how they work and run, because that will show your commitment to specialty as well, and also as well as give you that particular insight that you will be much more confident going into the interview setting.
Yeah, I mean, if you're part of the foundation program, you don't have a rotation in obstetrics and gynecology, you can ask for a formal 1 week taster. Obviously, I didn't do that because I had an O&G rotation. I was considering a 1 week taster in genitourinary medicine, but eventually it didn't work out because the trust I wanted with was not part of the trust that I was already in. and it was very difficult to coordinate things. So I gave up on that idea. But yeah, I mean, it doesn't have to be obstetrics and gynecology. You can spend 1 week in infectious diseases and do HIV, or you could do genitourinary medicine and show your commitment. So again, it doesn't have to be obstetrics. You could even do urology. You could be spending a time with an andrologist or with a urologist who deals with male infertility specifically, or erectile dysfunction. So that could evidence your commitment to the specialty, even though you are not in obstetric or even in anesthesia. If you are working in anesthesia, show an interest in obstetric anesthesia, and that will show your commitment to the specialty as well. So there are different branches that you can access. Just saying that you don't have an O&G job, you're going to run into difficulties is not the right way.
And as you said, that you need to pass the MSRA exam or give the MSRA exam before the interview. And then on the interview day, you will have a portfolio station in 2 clinical scenarios, which will be sort of linked scenarios.
Yeah, they are linked. That's the second interview. And your third interview will, so I don't know if the lay person always sits on the third interview or not, but anyway, mine had 2 consultants and a lay person. Again, the vignette was given outside the door. There were basically 4 patients and a relative, and different clinical importance. Again, non-obstetrics and gynecology. In fact, in that situation, I was the general surgery SHO. And you basically, it's a prioritization exercise. They want to know who you will prioritize and what resources will you use in terms of manpower and non-manpower. And how will you manage the situation? Because one of them will be someone who's complaining. You need to sort that out, and not necessarily first off, because clinical importance is more important. And then, so basically that whole exercise is all about prioritization. And again, knowing the system and knowing what all you can do as the SHO in residence. And again, non-O&G. So if you've done a general surgery job, you'll be equally at ease at answering that question as someone who's done an O&G job. So yeah, those are the 3 stations. Each of those stations contributes 25% of the marks. So 75% of the marks come from the interview, 25 coming from the MSRA. But as I said, things might change going forward.
All right. Thank you very much for the insight and sharing your experience. Have you got any advice general advice for IMGs who are currently working in UK? So and maybe at the junior level, or it's just about to start work in UK. How can they maximize themselves in the system?
So it was. So when I started my job, I felt very vulnerable because not only that I was so I had worked in the NHS in a non-clinical environment. So I won't say I was totally new to the NHS, but obviously on the clinical side, I was very petrified on my first day because there was no senior around, and the consultant, who was also my ES for the year, she just came on and we started going on the ward round. And immediately before she went into a side room, she asked the nursing staff, why are they in the side room? And then she started putting on her apron. And you know what? If she wasn't there, I probably wouldn't have done that, because I've not seen that in Pakistan. I've never seen that in clinical practice. So there were a lot of things I had to get used to it. There were a lot of terms being used. I was constantly Googling them on my mobile phone. So I was very like a fish out of water. I felt like it for certain. And I think that's going to happen with everyone who comes into the country. But let that not faze you. I didn't have any issues. There were no formal complaints made against me. I had a very smooth sale, thankfully, touch wood. Through the 2 years, I did a lot of things on the side in my personal time. I enjoyed things. I have 2 kids, one who was born during my application foundation program, and one who was born during my obstetrics and gynecology rotation. So there were a lot of things happening on the personal front as well. But yeah, I mean, I enjoyed my time. I rotated to some very different specialties. I went into psychiatry, which I had never experienced beyond my 3 weeks in Pakistan, which was all like during the Eid and Ramzan times. There were hardly any patients at civil hospitals. So it was all very theoretical knowledge. And then bang on, as an F1, I'm in obstetrics, in psychiatry. So that was a very big eye opener. And but yeah, it was interesting. Oh yeah, interestingly, in my psychiatry placement during F1, the consultant, who was my CS at that time, she actually had an interest in perinatal medicine. So she had specialty clinics in perinatal medicine. I asked her permission, and on a day where I didn't have that many jobs, or else a senior was available, a registrar was available who I can hand over to, and she gladly took on the jobs. I actually broke away and went and sat in those clinics. So even in psychiatry, I put obstetrics and gynecology up front, and I learned some aspects of it which were related to psychiatry, but obviously in an O&G setting. So again, as I said, in each of my jobs, I had obstetrics and gynecology at my back burner, and that's when I kind of always revisited it. So yeah, I did feel like a fish out of water. I'm sure every IMG is going to feel like it, but yeah, make the most of it. It's a learning opportunity. I've never done a non-training job, so I don't know how things would be that different. But when it comes to training jobs, there's a lot of help and support available. I can confidently say in my 2 years, I don't think I was mistreated simply because I was an IMG. In fact, most people don't know that. I mean, so like, unless you tell them, I mean, unless of course you're totally new. I've spent 10 years in the UK, but and I don't think I've developed a British accent, but then at the same time I don't think I sound like I've come from abroad right now. So maybe that's the reason why it's not apparent immediately. But even if it is apparent immediately, I don't think, I mean, there have been lots of people who worked with me in my jobs who were non-trainees, and they were from Pakistan, a number of them, a girl from Bangladesh as well. But yeah, they got on fine. Like, there was no difference between a non-trainee and a trainee, at least at my level, because you did the same job. You were entitled to the same number of annual leaves. You did the same number of hours. You were on the on-call schedule. You had an ES and a CS, and you had your portfolios to do. Yeah, you attended teaching. You had protected time for teaching as well. So yeah, there was no difference between a trainee and a non-trainee at the foundation program. So I don't think I was treated any differently. So to the idea that you are not in training and you can't do things that the trainees are allowed to do, that's nothing of that sort. I mean, even as a trainee, the budget I had for courses was limited. And for my obstetrics and gynecology, I went and did my ALS in obstetrics, which is no longer offered in the UK. And even if it was offered, so they just wanted to sponsor one training course for development in obstetrics and gynecology, and I chose to do my basic practical skills through the RCOG. So if I had to do another course, there was no funding for it, and more so because it wasn't one in the UK, it was unlikely that they would offer that. So I had to pay through my own pocket to fly to Greece. I went to Athens and I did the ALS and obstetrics over there. So even as a trainee, there are restrictions. You can't just say that, oh, trainees have a budget and they can do all these courses and we aren't facilitated. No, even as a trainee, there are limitations. And if you want to go beyond them, you have to unfortunately fish into your own pocket. So I had to spend my own money to go to Greece for that course. So yeah, I mean, to say that as a non-trainee, you are disadvantaged, I don't think that's true. So we need to get over that and basically make the most of everything. Everything's a learning opportunity, and enjoy life by the side. I mean, the UK is brilliant. The weather and it's not always great, but when it is great, you should venture out and make the most of it.
Oh, thank you very much for sharing your experience and the tips. I'm sure a lot of IMGs will find this very useful, and especially the ones looking towards ops and gynae training, they will find this very useful. Because this is one of the surgical specialties, and people are interested in surgical specialties when they're coming from abroad. So thank you very much for sharing your experience.
No, not at all. Feel free to contact me. I'm available on Facebook. Yeah, just drop me a message or on any of the forums if you want to share it publicly, or just message me if you want to know about the foundation program or obstetrics and gynecology. Definitely just shoot me a message and I'll do my best to answer those for you.
Thank you very much.